The Next Breast Thing podcast is primarily funded by the American Society of Breast Surgeons. The support of sponsorships helps us offset some production costs. ASBrS does not endorse or co-promote any company, product, or service mentioned.
This episode of The Next Breast Thing is made possible in part through the generous support of Solventum Prevena Therapy and Mammotome Breast Cancer Diagnostics and Surgical Solutions.
Solventum Prevena Therapy has demonstrated a significant reduction in surgical site complications, infections, and readmissions. Take a proactive risk management approach. With Prevena Therapy, learn more at Prevena.com. That's Prevena.com.
At Mammotome, we offer a comprehensive range of products that deliver better outcomes in breast care. From biopsy to surgery, our advanced technologies empower clinicians with precise, trusted solutions. Together, we will transform the future of breast care. Learn more at mammotome.com.
Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast wherever you listen to podcasts.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of The Next Breast Thing,
In this episode, we explore the physical demands of breast surgery.
with us today is Kate Kopkash. Kate is a nationally recognized leader in Oncoplastic and robotic breast surgery, surgeon ergonomics, and Oncoplastic.
I wanted to be a fighter pilot when I was a little kid, and I decided the next coolest thing would be being a surgeon. In the operating room, the most vital instrument is our bodies. 12% of surgeons have to cut their career short because of injury. I received no training in ergonomics in medical school, surgical residency, even my...
Probably about 7 years ago, I woke up with numbness in my arm.
My neck hurt for about 5 years.
Does the order of our cases matter? Should we be doing
What ergonomics do we need to be thinking about? Is it our neck? Is it our back?
In the operating room, you really want to work on keeping a neutral. And you want to be really cautious with headlights. So I know a lot of...
I don't want a cervical spine surgery when I'm 50 or something.
And if you complain, you're kind of a baby.
Is there new technology on the horizon to help us?
Absolutely.
This is Carla.
Ellie.
Michael.
Susie.
And Susan, welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community,
We're a group of devoted surgeons from different parts of the country.
inviting you to journey with us into the science of breast.
Through the heart and soul of our breast community.
From advances in procedures and patient care to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.
As breast surgeons, we spend hours leaning, reaching, retracting, and holding our bodies in really weird and demanding positions. Yet the cumulative physical toll is often really ignored until pain or even injury begins affecting our work.
In this episode, we explore the physical demands of breast surgery, practical changes we can make to improve positioning and reduce strain, and the emerging technologies and operating room innovations that may help protect us in the future.
Fortunately, we don't have to navigate this topic alone. With us today is Kate Kopkash. She's a director of Oncoplastic breast surgery at Endeavor Health and clinical professor of surgery at the University of Chicago, Pritzker School of Medicine. Kate is a nationally recognized leader in Oncoplastic and robotic breast surgery, whose work has helped establish national standards for robotic nipple-sparing mastectomy, surgeon ergonomics, and Oncoplastic training.
Kate has also played a leading role in our Oncoplastics program at American Society of Breast Surgeons. She frequently directs courses and is definitely faculty on many courses. But in addition to that, Kate is also an accomplished researcher and recently was first author on the U.S. multicenter randomized trial looking at robotic versus open nipple-sparing mastectomies. My understanding, and I've actually seen it firsthand, is you are an incredible mentor. And we need more people like you in our society and honestly in our field, because that's how we continue to move the field forward. So Kate, welcome to the Next Breast Thing. It's such an honor to have you here, and we're so glad that you've joined us today.
Well, thank you, Susan. That was a wonderful introduction, and I'm thrilled to get to be here. I've been listening to the podcast since the beginning. It's really helped me be a better breast surgeon to kind of stay up to date on the literature, and I am just so excited to get to be a guest.
As I say to many of our guests, be careful what you wish for. You never know what happens on this podcast. But before we dive into the conversation, which really I have so many questions, I'd like to hear a little bit about your story.
I grew up in a small town, a very far suburb of Chicago. I wanted to be a fighter pilot when I was a little kid. My mom told me girls couldn't be fighter pilots, which I think was factually correct in the early 80s. And I decided the next coolest thing would be being a surgeon. So I went to University of Illinois for my undergraduate education. I went to Rush University Medical Center, which is in Chicago, for medical school and my surgery residency. And I did my breast surgery fellowship at the University of Southern California. I actually went into surgical residency planning to be a cardiac surgeon, and I sort of realized that may not be the best life path for me, and I had to figure out what I wanted to do. And I had luckily done research in breast cancer. One of the summers between first and second year of med school, I loved the research being done in breast cancer surgery. And I was fascinated by breast reconstruction. I toyed with the idea of being a plastic surgeon. And one of my mentors at Rush told me about the field of Oncoplastics, where you get to combine cancer surgery and optimizing the cosmetic outcomes. And I was hooked. And the rest is history. So I am thrilled to get to be a breast surgeon and do what I love every day.
I have to say, I'm very grateful to whichever mentor that was of yours. It's a great choice of careers for you. So Ellie, I don't know, I saw you light up when she said Southern California. I mean, all you do is need to mention the region and you just lit up. So Ellie, we'll let you start since you're so excited about the region.
Well, I am. I love it. Kate and I went through the same fellowship, so a lot of love in my heart for what she's been through in her training, and very much appreciate everything that you're doing, Kate, to also propel forward the mastectomy side of things with the robotics. So really thinking about breast surgery and what we do every day in our lumpectomies, in our mastectomies, what ergonomics do we need to be thinking about? Is it our neck? Is it our back? Is it our hands? We use our hands so much for retraction and everything. When you kind of think about this, how do you prioritize what we should be thinking about for a really long career? Because I know I've seen those surgeons kind of hunched over and hobbling around the hospital. I don't want to be that person. How do we avoid that?
Absolutely. So when it comes down to it, in the operating room, the most vital instrument, the only thing that is needed to complete our surgery that we cannot do without is our bodies. When it comes down to it, we are the most important instrument. And I think we spend these thousands of hours learning, studying, taking tests, sitting in lectures. But as surgeons, we're also technical. We have to be able to perform, and that uses our body. And unfortunately, I received no training in ergonomics in medical school, surgical residency, even my fellowship. When they do studies, they see it's very rare to have ergonomic training along the way. So it kind of comes down to we have to protect ourselves to have career longevity. When we look at work-related musculoskeletal disorders, what parts of our bodies get hurt as surgeons? It shows cervical spine, rotator cuff, lumbar spine, and carpal tunnel issues. And I think all of us sitting here can probably think about the times those parts of our bodies hurt, or possibly we've had to have interventions. When we look at studies, it actually shows the factors that are associated with increasing problems in these areas are being female, less years in practice, and younger age. So that's our society. Junior surgeons that are female and starting out, this is a real problem, and we have to help fix our future because no one else is looking out for it. We look at long-term studies that follow surgeons, and they look at these work-related musculoskeletal disorders. 12% of surgeons have to cut their career short because of injury. And in the end, this comes from not prioritizing our ergonomics in the operating room.
So you said young in your career. Is that because you're working harder? You haven't realized how important ergonomics are? Or is it as we get older, we have residents and fellows and PAs working with us? Which one is it and why?
I think it's a great question. And I've never seen that in the data. I would have to imagine it's kind of all of it. So when we're junior faculty, we oftentimes have the least experienced first assist. We're often working with either the junior resident or a medical student or the very inexperienced PA. I think we're also probably more likely to overexert ourselves in the sense that if they give us 2 or 3 rooms for that day, we'll do those 10 cases in one day. While maybe when we're older and wiser, we'll say that's not a great idea. And I also do think that junior faculty don't have the same optimized operating room schedules. So they are being forced to maybe work in ways they wouldn't want to. So meaning operating 1 very long day as opposed to 2 shorter days, possibly doing 6, 8 nipple-sparing mastectomies in a day as opposed to spreading it out over the work week. So I think it's probably all of those factors.
So let's talk about that because this is perfect timing. I had 4 or 5 cases today. The last was a bilateral mastectomy on a woman with a BMI of about 45. And sitting here right now, I am so uncomfortable. What could I have done to make it better? And does the order of our cases matter? Should we be doing the really hard cases first or last? Or when I'm doing a case with plastics, I want that to be the last case because I don't want to wait. We get 1 room. I don't have multiple rooms. So I always put that case last.
Let's look at it in kind of each part of that question because that is such a great way of looking at it. So I think there's things we can fix and optimize in our operating room. There's things we can optimize about ourselves. And then there's things we can optimize outside of the operating room. So in the operating room, you really want to work on keeping a neutral stance. And that means your arm, forearm, and shoulder should be at a 90-degree angle, so that nice neutral. Your core should be engaged. You should be standing up straight, not leaning forward. And the table height is just critical. The table needs to be at the right position for the tallest person in the operating room. So that means everyone else needs to be at steps because there's no way for a tall person to be shorter. I actually sit for a lot of my cases because I am 5'10", and I think it's dangerous to have some of my team on 2 steps and things, but you really need to optimize the table height. The positioning matters. So I use table tilt a lot with my surgeries. I'm often putting a patient into reverse Trendelenburg to allow gravity to help bring the gland towards me during nipple-sparing mastectomies, or do it into Trendelenburg to bring the gland away from me. I want to have the table moving the patient as opposed to me moving my body. I want to take micro breaks during surgery. So every 20 to 40 minutes, just taking 60 to 90 seconds to move, stretch out your hands, your shoulders, have your first assist do this as well. You can definitely do this sterilely. There's been studies that have looked at this. There's even exercise protocols that can be done during surgery. So micro breaks help improve the subjective feelings of physical well-being at the end of an operating room day. And it also helps improve our mental focus. And it does not add time or duration to the surgery. And this is you and your team that it helps improve these outcomes for. When you think about your instruments in the operating room, you want to be thoughtful. If you are holding a grasp on an object such as a lymph node clamp, instead of using, for example, a DeBakey when we're dissecting a sentinel node, I'll often take a Betcher and clamp right next to the lymph node. So then my hand is not in this contracted position. Instead, I'm using a clamp. You want to focus on having your hands and your wrists in a neutral position whenever possible. And you want to be really cautious with headlights. So I know a lot of people like headlights, but headlights seem to put our heads into an abnormal position that puts tension on our C-spine because we're having to turn our head to make the light go in the correct direction. These are things you just need to be aware of, and especially if you have cervical spine issues, you want to think about using something like a lighted retractor so you're not using your neck in that way. In terms of the things we can do to improve ourselves in this role as a surgeon, it's exercise. I know it's boring. It helps improve everything, but resistance training helps decrease the risk of work-related musculoskeletal disorders. Maintaining a healthy body weight matters. In terms of outside of the operating room, I do think that working with our scheduling teams in order to make sure that our bodies are not being physically stressed in such a way that we know is going to lead to discomfort. So I know you said, should you do your hardest case first, your hardest case last? We do know that fatigue increases throughout the day. And unfortunately for scheduling, we're often doing, like you said, some of our most physically demanding cases last, which from an ergonomic standpoint might not be the best option.
Ellie, being so young in your career, are these things that you have thought about and acted on? Because we discussed this at our annual meeting. I know Kate has been on the podium multiple times speaking about this, but have you really day-to-day, do you think about this?
So I actually do to a degree. So I am not as tall as Kate, but I'm 5'9", and in general surgery, all of my attendings were about 5'3". So my tables were always at the floor, male and female. They were all just a lot shorter than me. And so my neck hurt for about 5 years. So the second that I could control that table height, oh my God, I was so excited. I didn't necessarily think about it when I was a general surgery resident, but those things she mentioned about my elbows being at 90 degrees, that is the first thing I do, is I make sure the table height is, because I'm often the tallest person in the room, I will make sure that the table height is so that my arms are at 90 degrees. I'm a little sad to hear about the headlight thing because I freaking love my Ronin 6 headlight and couldn't live without it.
You could be the first person that I've ever heard say they love their headlight.
I love my headlight.
Why?
I don't have to touch the lights. I don't have to mess with them. I also have a lighted retractor that I use too, but I tunnel a lot.
I went into breast surgery so that I wouldn't have to use a headlight.
I'm not plugged into anything. It's light. I've worn it enough times that it's kind of like my third eye there. And I know exactly where to put it, but it took me a very long time to figure that out.
Change that if you would like a long career. Kate just told us you have to change that.
To be fair, Ellie, I do think the studies that looked at headlights, those were the old type. So the lighted, connected to the light box. Right. So I do wonder, that would be a great study to look at now that they have these battery pack headlights, because you're not doing that compensation with your neck.
Right. Well, and I chose that because that is what the flap surgeons were using after 12 hours. And I asked them, does your neck hurt after? I don't want a cervical spine surgery when I'm 50 or something. I don't want to do that. So I do think about it a little bit, probably not as much as I should. I definitely don't take micro breaks like she's mentioning. And it's really interesting that you talk about that, Kate, because there's a lot of like business literature around that. And like really productive people, they force themselves to take breaks every 40 to 50 minutes, and it boosts their productivity. And a lot of CEOs are like recommended to do that. So I love that that's in the surgery literature too. Honestly, I've had to learn the hard way throughout my early career when a day is too much. I'll say to my scheduler, my hands weren't working after this bilateral nipple-sparing mastectomy that I did with scissors. Like, you can't give me 5 cases on those days. I'm learning my limits. And the ergonomics make all the difference, because when I have the ergonomics, I can do more versus when I don't, my hands are cramping and all that. So I really appreciate this topic being covered, because I think we need to think about this as early as possible.
In the OR, everyone makes fun of me because I have the table high. And when plastics come in, they literally have the table as low as it will go. was like, how do you do this? I don't understand. So even anesthesia makes fun of me. They're like, oh, bubble height. And it's not as though I'm 6 feet tall, but I think it's really important. I feel the difference when the table is too low. I absolutely do. Michael, along your career, how much thought have you given to this?
I can't believe I'm going to say this.
You're listening to the Next Breast Thing podcast. We'll return in a moment after this brief message from our sponsors.
What do surgeons want? Not having to wait on nuclear medicine makes our day much more efficient.
With MagTrace, we can start now at 8:30.
It decouples those appointments from radiology and helps with patient experience also.
The efficiency that is afforded has honestly revolutionized my day.
Hologic, redefining breast care from screening to surgery. MagTrace is a registered trademark of Hologic. Julie Margin-Thaler, Crystalline Gallagher, and Michael Boland were paid consultants for Endomag. For MagTrace indications, warnings, and precautions, please reference the instructions for use at eifu.endomag.com.
Breast cancer recurrence doesn't wait for symptoms. Signatera is a tumor-informed circulating tumor DNA test that detects molecular residual disease months before imaging. From neoadjuvant response to long-term surveillance, get unparalleled insights to inform next steps. Signatera is backed by Medicare coverage and more than 175 peer-reviewed studies. Learn more at natera.com/Signatera.
And now, back to the Next Breast Thing.
Michael, along your career, how much thought have you given to this?
I can't believe I'm going to say this, but
boy.
I was wrong throughout my career. A lot of it came from just the stupid old time, if you're not suffering, you're not operating. We're going to do about 6 cases because breast is a volume practice and we're going to churn through it. We're going to do it quickly and we're not going to stop and reposition the table because that kills time. And we're not going to use a cautery tip extender because that might cost an extra $0.50. If you can operate without it. And then we're in the clinic and we're always looking down and we're doing the biopsies. And if you complain, you're kind of a baby. Well, that caught up with me. Probably about 7 years ago, I woke up with numbness in my arm and ended up getting an MRI and ended up getting some steroid injections. And after about a week, it resolved. But 2 years ago, it didn't resolve. And I had excruciating pain and numbness in my left hand. And I've had to have a 2-level anterior cervical discectomy and fusion. And that pain was a pain that I have never experienced in my life. And just waiting for that surgery was the longest time I've ever waited. And honestly, I did it to myself. It's not like I was in a car wreck that I didn't cause. This was bad decisions every day for 20 plus years that added up. It really wasn't even a disc as much as an acute deal. It was bone spurs. And you talk to the neurosurgeon and the orthopedist, and they say, it's just that repeated looking down. You go, this is typical for a surgeon.
It's the headlight.
Oh, I didn't even use a headlight because that was a sign of weakness. I mean, I'm telling you, I did nothing to improve my well-being. And if anybody complained, I made fun of them. And so I wasn't going to do that. And I paid the price.
Sort of like victim blaming. I wouldn't blame you. We just didn't know better. And
that is
one of the reasons why we're doing this episode, and one of the reasons why Kate's on the podium frequently at our meetings is we do know better, but we have to teach each other how to do better. We are responsible for teaching our fellows and residents and medical students this information. It is really important information. So I don't think it's any of our fault. I think we just weren't taught this.
My fellows too. I need to, if they're listening, I apologize. I was wrong. You were right. I did it wrong.
It's so true because I think you would never let one of your chief residents explain to you the management of breast disease incorrectly. If they explained something wrong with the surgery, you'd correct them. But yet if we see our chief resident hunched over with a craned neck, oftentimes no one's saying anything. And this has to be part of training. We have to be teaching ergonomic. We have to at least be talking about it. We have to do better for our next generation.
How much of your ergonomics And I know it's a secondary benefit. Did that drive you into robotics, or were these just two separate interests that just happened to work for each other?
The reason I started the robotic research was the ergonomics.
Really?
I was 4 years into my career. I was doing a lot of prophylactic nipple-sparing mastectomies and BRCA carriers, which still is a huge part of my practice. And I saw the writing on the wall that this was not sustainable. I was not going to be able to be doing 3 bilateral nipple-sparing mastectomies 2-3 days a week for the next 30 years. It just wasn't going to be possible. And I didn't want to give up my career, but I knew there had to be better ways to do this. And I started looking into the robotic approach. And I think as surgeons, we're also taught to not talk about that, right? We're supposed to say every single thing we do is to better things for the patients. And I think there are some very compelling data we have seen with the robotic nipple-sparing mastectomy that may show benefits for patients. But what actually started my interest was trying to improve ergonomics for the surgeon. Essentially, the neck pain I was having at the end of every OR day, I knew I had to do better. I was trying to optimize my ergonomics in the operating room. I was doing strength training, stretching after my cases. And it just comes down to the sight line that we are in to perform an open nipple-sparing mastectomy is not ergonomic. And we can optimize it. We can use the right retractors. But just the way it is done, the visualization, the viewpoint we're at. We did a study that looked at this a couple years ago, and we had an ergonomicist come in and look at what we were doing. They essentially said, there's no way to make this better. We can try, but it's just the way the surgery is done. It is a horrible ergonomic positioning. So I do think that the robotic approach, I know my initial interest started in order to improve our ergonomics. One of the data points for the U.S. randomized multicenter clinical trial that looked at robotic NSM versus open NSM was surgeon ergonomics. And we did it subjectively with a questionnaire, but we also did a sub-analysis where I wore EMGs during every single robotic case on trial, which I also had done before our trial for some early ergonomics work. And I'm really excited to get to analyze that data and hopefully present it in the very near future. But obviously, there's ergonomic issues with everything. And when we look at robotic surgeons, they have these same musculoskeletal disorders. It's just different areas that are affected. So you're exactly right. It's just affecting different muscles. But we have to look at globally, is this decreasing injury? And I don't know if we have enough data to say that yet. I think time will tell here. But I think looking at it and trying to say, how do we improve this is the first step.
Right, because we all hear that sitting in the chair is also the death of us, right? That's our lumbar spine is, degrading.
Your hands, that carpal tunnel.
So it's right. Are we trading our neck for our lower back? These operations are just tough on us, kind of no matter what it sounds like. But Kate, so let's go to a situation. Let's say someone doesn't have robotic capability at their hospital. You basically said that the open nipple-sparing, there's no way to make it perfectly ergonomic, but if you were consulting someone, what should they do to set up their nipple-sparing so that they are at the best advantage during that operation? Because we also want to think about the in-between where we are now, and a lot of people don't have access to these different ways of doing it. So how would you counsel someone to set that up as a surgeon to, won't be perfect, but what should they do?
Yeah. So I think optimizing your table height. So whether that is having your table higher, so you're at the better visualization point, or sitting in order to do that. I think using the table tilt, and we're specifically talking about open nipple-sparing mastectomy here, because let's be honest, that's the worst one. So I think making an incision that's large enough for you to be able to visualize. I have definitely had people talk to me at the national meeting and things about, well, I'm able to do my NSMs through a 6-centimeter incision. And I'm like, wow, mine's probably double that. I'm big, I have big hands. I need bigger. So make your incision big enough that you can see, and you're not having to put your neck and your head in very odd positions in order to visualize, because we have to be able to see to operate. Initially, when I'm doing an open NSM, I do my anterior dissection first, and I start with my table in Trendelenburg. So the gland is actually being pulled away from me. So that kind of opens up the area for that anterior dissection. And then when I hit the level of the nipple, I go into reverse Trendelenburg. So then again, the gland's kind of coming down to help me get up and over. When I'm working on that upper outer quadrant, that's hard, right? Because usually if we're operating on the right on the upper outer quadrant, you're kind of craning in to see it. A lot of times I'll go over to the other side of the table. Takes me probably, 7 seconds to walk to the other side of the table, but it allows me to be in a much more comfortable ergonomic position. we have our patients with usually 2 straps, one around right above their knees, one around the hips. So I'm able to do a lot of table tilt. So I am often, when I'm working that upper outer quadrant, I'm using the table tilt to help me. I'm tipping it forward towards me. When I start the case, I kind of have the nipple always going right up towards the ceiling. So that usually requires table tilt. And those ergonomic positions are going to help you. I usually do our micro breaks after I do the anterior dissection. That takes me, right around 20 minutes. And that's when, as we're switching the table, that's when me and my first assist, we stretch out. My scrub nurse does it too, just in solidarity. But I think those micro breaks really do help. And I have no qualms in standing up, stretching out my legs during a case. I tell my first assist to do the same thing. But I think those little changing to our positioning matter a lot. I don't wear a headlight, but like I said, maybe if we're wearing one that doesn't go around the head and doesn't have a cord, that may be different. I use a lighted non-conducting retractor, so I'm able to visualize. I also use a protected extended bovie tip, so I'm not having to, again, get my hands into those weird far positions. And I do think those little changes do really help.
So, Kate, let me ask you something. We have spent a lot of time talking about nipple-sparing mastectomies, and I hope all of us do them. It sounds like it's the bulk of your practice, but it's not the bulk of the average breast surgical oncology practice. If we look statistically, it's partial mastectomies or lumpectomies. If we talk about hints for the bulk of what most of us do, how can we do it? Table height, yes.
Lighting, so you're not craning your head to see there. Again, those lighted retractors really help. Visualization, so getting the incision where you need it. I think this is the beauty of the periareolar incision or a big inframammary fold incision, because you can make the incision large enough to be able to see. I think a lot of us probably early in our training were taught, make an incision right over the tumor, so you tried to make it really tiny because you didn't want a big scar. And now we know we can hide the scar and it opens up that dissection plane. So we're not in those, kind of contorted small spaces. It is hard for 2 people to see at the same time, right? It's hard for you and your resident or fellow to see at the same time. And sometimes just working around who's standing where, so your visualization is better than you trying to crane your neck around a corner. And then the idea of sitting, I think sometimes having one of you sitting, one of you standing can kind of help make the table position work for both surgeons.
One of the other things that really I'm wondering about, because we're getting into more and more nerve-sparing mastectomies, and then combine the nipple-sparing and the nerve-sparing, we're sparing everything but ourselves. So how does wearing loops affect all of us?
Yeah, so I do know there's been some studies that have looked at this, and oftentimes it's hard to say, is it the chicken or the egg, right? So surgeons that are wearing loops are usually doing surgeries where their C-spine is compromised or put in these really uncomfortable and, poor ergonomic positions. So it is hard to say, is the surgery being performed the problem that's causing the C-spine issue, or is it because the surgeon is wearing the loops? Specifically in our realm, it'll be interesting because I do think that more breast surgeons will be wearing loops for the exact reason you said. And we'll have to see how that affects their ergonomics. I think, again, just keeping those ergonomic principles of keeping your neck in a neutral position, taking micro breaks, adjusting the table and your instruments to suit your surgery, those are always going to be paramount to help improve our ergonomic workloads overall.
My last question, is there new technology on the horizon to help us?
Absolutely. I do think that the robotic approach, the endoscopic approach to nipple-sparing mastectomy may help with some of the ergonomic concerns, or it may open up other ergonomic concerns. There is a lot of research being done now compared to 10 years ago into surgical ergonomics. There are some really cool innovations like exoskeletons that are being worn by surgeons to help protect their positioning during surgery and avoid hyperextension. And I think the fact that it's something that many of the major societies are talking about now is going to make it something that's being taught in medical school and a residency. So I think just awareness is our first step to improving the future.
I had mentioned, what can I do to my neurosurgeon about it? He says, well, they've got a camera that will project to a screen in front of you. And I thought, well, there's no chance on earth that I'm going to get my surgery center to foot the bill on that. I didn't even know that existed. But evidently there is a camera and now you're operating looking straight ahead as opposed to looking down. So that was interesting to me. I didn't know it existed.
Yeah. I mean, we have a looming workforce shortage. There's no question. And if we can keep surgeons working longer and healthy, that is going to have huge public health ramifications. So I agree that I think none of us think our universities or our surgery centers want to pay more, but it's a lot more expensive to find new surgeons and train new surgeons. So I think preserving the longevity of our careers does matter, and probably in the end matters financially.
Kate, we've run out of time again. I'm frequently left with more questions than I started with, so we'll have to have you back. But thank you so much for joining us for this episode. It's really inspiring to talk to you about this because I feel the passion come through, and I am sure that all of our listeners will also.
Thanks so much. I really appreciate it.
To our listeners throughout the entire breast community, we're so excited you've joined us on this journey, and we'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
and Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.